And we have Dr. Pradeep Sagar, who's a consultant vitro retina services from Shankara Eye Hospital, Shimoga. And he is going to be telling us guidelines on use of OCTA. On to you, doctor.
Thank you, ma'am. Are my slides visible?
Yes, yes.
I would like to thank Dr. Chitra ma'am and AAOC for giving me this opportunity. I'll be discussing on the guidelines on use of OCT angiography and standardization of OCTA reporting. I have to make it clear that there is an ongoing attempt to frame the guidelines and standardize the terminologies related to OCTA, and the guidelines are not available yet in all clinical scenarios. So my presentation is mainly based on a few attempts, a few articles which have tried to standardize the OCTA nomenclature in different retinal conditions. So first, I will be discussing the guidelines on use of OCTA, the utility of OCTA in clinical conditions, and what protocols to order. So the clinical conditions, the most common would be the diabetic retinopathy. There was a consensus among the experts that a set of OCTA parameters should be included in staging of diabetic retinopathy, which includes the vascular density, the foveal avascular zone parameters, the amount of flow deficit areas, presence of intraretinal microvascular abnormalities, and presence of neovascularization. So the other important condition is macular ischemia. We all know that OCTA is very helpful in detection of macular ischemia, and a strong consensus was there among the experts that it is helpful. But we know that there are various other FAZ parameters such as the A circularity index, the FAZ area, and there was no consensus among the experts on which parameter should be used to define the presence and the severity of macular ischemia. We know that in macular edema, the assessment of macular ischemia could be complicated by segmentation errors and the presence of cystoid spaces. Here we can see an example in which we can see in the superficial capillary plexus, even though there is edema, it is less affected and we will be able to assess the foveal vascular zone. Whereas in this case, we can see that due to the segmentation artifact and due to a very thin inner layer of the cyst, the FAZ appears to be enlarged and it's a false impression. So there is a need for standardization and need for guidelines on utility of OCTA in macular edema in cases with macular ischemia. Moving on to retinal vein occlusions, there was a consensus among the experts that more than 30-degree absolute decrease in flow area has to be used to define ischemic CRVO from non-ischemic CRVO, but there was no guidelines on classifying BRVO. So in uveitis, the experts opine that it helps in the detection of CNV neovascularization elsewhere and neovascularization at the disc. There was consensus among the experts on the definition of the neovascularization elsewhere and neovascularization at disc. That is, it was defined as a supraretinal flow with breaching of ILM on the OCTA cross-section and presence of an irregular dense network of vessels on a OCTA enfase. But the consensus regarding the use of the term macular neovascularization, which was advocated by the consensus on neovascular AMD nomenclature group, was not accepted by the group on uveitis experts who felt that the terminology may not be applied to inflammatory choroidal neovascular membranes. We know that OCTA plays a very important role in diagnosis and management of AMD and pachychoroid spectrum diseases, but as of now, there is no guideline on use of OCTA in these conditions. So what scanning protocol to order? We know that there are guidelines to say that neovascularization has to be used for the staging of diabetic retinopathy, which can be detected on Opta. But here we can see that there is an example. This is a wide field, a 9 into, technically not wide field, it's a 9 into 9 mm scan in which the NVD is not very well evident, whereas in a 4.5 mm scan, we can see that the NVD is very well seen. Similarly, here we can see that there is a flat irregular PED on OCT. There is no obvious network on 6 mm octa, but a 3 mm octa shows a network. So what we need to understand is that it's not just that what parameters have to be included, it's also that we need a consensus on what scanning protocol has to be used in order to identify these entities. But as of now, there is no consensus in this field. So moving on to the terminologies used in OCTA reporting. So wide field OCTA. There was a consensus among experts in the field of retinal vascular diseases that more than 90-degree field of view should be considered as wide field, and the experts in the field of uveitis suggested more than 70-degree field of view as wide field. So what we need to understand is the manufacturers have to provide a field of view of each protocol for this standardization. So the area of reduced signal, we see in OCTA the areas with reduced signal, and it has been termed in literature with various terminologies such as flow void, capillary non-perfusion, grayish area, no flow area, flow deficit, flow attenuation, and so on. So there was a strong consensus on classifying the reduced signal on Octa based on the cause. For example, it can be due to absence of perfusion, as we can see over here. But we have to understand that it would not be possible to be certain that it is definitely an absence of flow, as even a low flow may be seen as a reduced signal on OCTA. So the reduced signal can also be due to a low flow, as I already mentioned. For example, within an aneurysm, here we can see that there is an aneurysm, and here we see that this area is seen as a reduced signal. The reduced signal can also be due to vessel displacement. For example, in cases with cystoid macular edema, here we can see that due to the presence of this inner retinal cyst, we see that there is an area of reduced signal. So it has to be classified separately. And it can also, the reduced signal can also be due to presence of hemorrhage or hard exudates, which results in blockage. As we can see over here in this choriocapillary slab, we see that there are areas of reduced signal, but this is actually due to blockage and not a true reduction in flow. So though there was a consensus on classifying the reduced signal based on the cause, there was no consensus on what term has to be used. In the discussion, there was this term used, which is the decorrelation signal. That's the reduced decorrelation signal, which actually seems to be appropriate because in OCTA, what we are measuring is the decorrelation signal. But the experts were not comfortable with the term decorrelation signal, and they preferred the term signal abnormality, and they used the term signal abnormality due to projection artifact for flow change due to projection artifact or projection artifact removal, signal abnormality due to flow displacement for flow change due to vessel displacement such as cystoid macular edema, and flow deficit for flow change due to ischemia. But they specified that none of these terms should be officially recommended for now. So the term large flow decrease was defined as a reduced flow area of more than 30% of absolute imaged area. They defined a meaningful change in percentage of flow on wide field Octa as an increase or decrease of more than 30%. And moving on to the reporting of quantitative parameters, there was a strong consensus on use of automated measurement in square millimeter using OCTA manufacturer software to measure the reduced flow area, as like there are various other like parameters, the quantitative parameters other than just the reduced flow area, but there was no consensus on those. And the consensus was that if the manufacturer does not provide an automated software, a third-party software such as an ImageJ can be used. I would just like to point out that, like, you can see that this is a 4.5 mm scan and the 6 mm scan, and this is of the same eye captured at same time, but we can see that the vascular density measured in these two are different. So what we need to understand is it's not just that the automated software, we have to specify that which particular protocol has to be used. Then only we'll be able to get a standardized reporting. So to summarize, guidelines on use of OCTA has to be tailored for each disease pathology, and it may not be same. And standardization of terms and recommendations on use of specific protocol is required for each entity. And there's an attempt in this direction, but further progress is required for a better standardization. Thank you.
Thank you. Thank you very much, Dr. Pradeep. You tried to make it as clear as possible. I would ask Dr. Jatinder Sinwas just one question from neither of you. we should go on to our next talk. And Mr. Sunil, can you start timing? I should have asked you right from the beginning. Are you there, Mr. Sunil? No. Yes.
Dr. J, can you shed more light on what's there for the future? Like, how do you think this terminology, or which are the most acceptable terminologies so far? I mean, Dr. Pradeep has done a very like excellent job summing up everything. But just two take-home points. What are the signals for freshers or for exams? If you have cases, what are the things that should be? What are the terms that should be used, like in general communication?
I think that we are really far from bringing everything into a standard use. I think we are just reaching to the OCT. OCT NGO is still far away. But I think using the term reduced signal or signal abnormalities is going to be, I think it is going to be pretty much acceptable. But more important to me for the beginners would be that, you know, Rupak's talk on OCT artifacts, because that is something which we should be looking much more carefully and making sure that what you are interpreting is actually the real pathology instead of just an artifact. So nothing much to add, because I think Sagar, Pradeep covered it really well. I'll just let the next speaker speak, considering the time shortage we have.
Yeah. Thank you very much.